Welcome to Board Pearls. This is episode 2 of the Steatotic liver disease chapter in the liver disease module. This episode is alcohol-associated liver disease, the spectrum from steatosis to alcoholic hepatitis to cirrhosis, severe alcoholic hepatitis identified by the Maddrey function or MLU with prednisolone after infection is excluded, the Day 7 Lille response decision, and early transplant for selected patients. Alcohol-associated liver disease is a single biology read across 3 histologic stages, where the drinker who walks in with simple steatosis at year 5 can return at year 15 with cirrhosis, and most of the teaching is about the rate at which one stage transitions to the next. Nearly all heavy drinkers develop steatosis. A fraction progress to alcoholic steatohepatitis or fibrosis, and a smaller fraction of all patients with alcohol use disorder eventually develop cirrhosis, with the cirrhosis risk rising steeply with daily intake. Steatosis is fully reversible after a few weeks of abstinence. Steatohepatitis clears in about half of patients who stop and progresses in a third, with that fraction climbing sharply if drinking continues. And once cirrhosis is established, decompensation and liver cancer both accrue at a few % a year. The mechanism explains the lab pattern and several drug interactions. Ethanol is oxidized by alcohol dehydrogenase to acetaldehyde and then by aldehyde dehydrogenase to acetate, both steps consuming NAD and generating NADH, and the resulting shift in that ratio inhibits fatty acid beta oxidation, which is most of why alcohol drives steatosis. Acetaldehyde itself is toxic, forming protein adducts that act as neoantigens and recruit immune injury, and chronic drinking induces the microsomal ethanol oxidizing enzyme, generating reactive oxygen species, which is also what makes the chronic drinker susceptible to acetaminophen toxicity at therapeutic doses, accelerates isoniazid injury, and worsens methotrexate fibrosis, while glutathione is depleted and gut-derived endotoxin translocates across an injured intestinal barrier to activate the liver macrophages, producing risk modifiers explain why one drinker at a lower intake develops cirrhosis, while another at a higher intake stays at steatosis. Women carry higher injury risk at lower exposures, because they have less body water and lower gastric enzyme activity and reach higher blood levels per drink, the same genetic variants that drive metabolic disease modify risk. Coffee is protective. Hepatitis C plus alcohol drives faster fibrosis than either alone. Metabolic disease overlaps biologically, which is why the intermediate category exists, and post-bariatric Asian populations carry a loss-of-function variant in the second metabolic step, so carriers can't efficiently clear acetaldehyde, and a single drink produces flushing and nausea, which makes most of them drink less so it's overall protective. But the carrier who drinks anyway, despite the flush, runs higher acetaldehyde exposure and higher upper aerodigestive cancer risk, and develops injury at exposures that wouldn't produce disease in non-carriers. The lab pattern outside the severe hepatitis syndrome is recognizable. Hepatomegaly with the AST greater than ALT, the ratio above 1.5 and often above 2, with both transaminases typically under 400, an elevated GGT and ferritin, and a blood count showing mild macrocytosis and thrombocytopenia. The AST greater than ALT pattern has a mechanism. Because alcohol is a mitochondrial toxin, and AST has a mitochondrial isoform, while ALT is cytoplasmic, and depends on vitamin B6, which is depleted in chronic drinkers, lowering the measured ALT. And when transaminases exceed 400 in a drinker, you should be thinking about something on top of alcohol, classically acetaminophen or ischemic hepatitis, because pure alcohol injury doesn't push the transaminases into the thousands. That sets up the acute syndrome sitting on top of underlying disease. Severe alcoholic hepatitis is the patient who develops rapid onset jaundice in ongoing heavy drinking, often with fever, leukocytosis, hepatomegaly, and decompensation, with the lab pattern being the transaminase ceiling under 400 with the same ratio, a bilirubin above 3 and often much higher, an elevated INR, and low albumin. The 90-day mortality is 30 to 40%, and that number is the urgency signal on every question the disease raises. The consensus criteria for probable alcoholic hepatitis have 4 components: jaundice with onset within the prior couple of months, heavy alcohol use for at least 6 months with fewer than 60 days of abstinence before onset, an AST between 50 and 400 with the ratio over 1.5, and a total bilirubin over 3, which lets you make the diagnosis without biopsy in the typical patient. With biopsy, increasingly transjugular because of the coagulopathy, reserved for atypical presentations. Severe disease is then defined by two prognostic anchors to know cold: the Maddrey discriminant function, computed from the prothrombin time and bilirubin, with a value above 32 defining severe disease, and the MELD score, which has largely replaced it because it's more reproducible and includes creatinine with a value over 20 defining severe disease for treatment purposes, and MELDNA is not used here. The trial that gives the modern treatment at SHAPE randomized patients with severe disease to prednisolone, pentoxifylline, both, or placebo, and prednisolone, produced a modest mortality reduction, while pentoxifylline produced no benefit and was dropped from guidelines. And the trial also clarified the safety cost, because serious infections were roughly twice as common in prednisolone-treated patients, which is why every patient screened for steroids must first be screened for infection. So the treatment is prednisolone at 40 mg daily for up to 28 days, or intravenous methylprednisolone when oral isn't possible, with the contraindications being the careful part: uncontrolled infection, acute kidney injury with a creatinine above 2.5, and uncontrolled GI bleeding all defer or contraindicate steroids, as do active viral hepatitis, drug injury, liver cancer, pancreatitis, HIV, tuberculosis, and multi-organ failure. So the workflow is to culture blood, urine, and acidic fluid and image the chest before starting, then a 1 to 3 day observation window to stabilize and exclude occult infection, which is why the median time from admission to steroids in the trial was several days, reflecting how much screening the protocol requires. The Lille model is the response score that determines whether to continue or stop, calculated at day 7 from age, albumin, prothrombin time, bilirubin, creatinine, and the change in bilirubin over that week, with a score under about half identifying responders who complete the full course with substantially improved survival, and a score at or above that threshold identifying non-responders. The critical move on non-response is to stop the steroids, because continuing past day 7 in a non-responder doesn't improve survival but keeps adding infection risk, so the day 7 decision is binary in its consequence. Responders continue, non-responders stop and get evaluated for early transplant. Acetylcysteine has supportive evidence as an adjunct, lowering 1-month mortality partly through fewer hepatorenal and infectious events, so it's a reasonable add-on in patients who can receive steroids, while pentoxifylline is no longer recommended and other agents are in trials. Nutrition is consistently mortality-modifying and non-negotiable, with a target of 30 to 40 kilocalories per kilogram a day and 1.5 grams of protein per kilogram, by mouth or nasogastric tube, because very low voluntary intake predicts near-complete mortality while adequate intake cuts it substantially, and parenteral nutrition is avoided because of infection risk, with thiamine repletion, withdrawal management, electrolyte correction, and continuous infection surveillance completing the package. That brings the patient who fails medical therapy, whose 6-month mortality without further intervention is high, most dying within 6 months. The historical answer was that transplant required 6 months of demonstrated sobriety first, but that rule was a center policy, never validated as a predictor of post-transplant abstinence, and it effectively excluded severe alcoholic hepatitis because most patients died within 6 months. A landmark study then tested early transplant and highly selected steroid non-responders, and found markedly improved 6-month survival, with a low recidivism rate in line with abstinence after the conventional rule, and a subsequent multicenter experience confirmed 1- and 3-year survival comparable to transplant for other indications, with a minority relapsing, whose predictors were younger age, prior alcohol-related consequences, and inadequate insight. So the field has retired the 6-month rule in favor of a structured psychosocial assessment that selects the patients most likely to maintain abstinence regardless of disease timing, centered on a multidisciplinary review, including addiction medicine, hepatology, transplant surgery, social work, and psychiatry, with the widely used scoring tools rating readiness, support, stability, and substance use effects. The favorable selection criteria are concrete. This must be the first liver decompensating event. The patient must have failed or be ineligible for medical therapy, which usually means a day 7 Lille above the threshold, or a steroid contraindication at the outset. There must be a supportive social network with close supports actively engaged. No more than 1 prior treatment attempt should have failed. There must be no other active substance use disorder and no untreated severe psychiatric disease, and the patient must demonstrate insight and commit with the family to lifelong sobriety. So the favorite vignette is a first decompensation patient started on prednisolone, whose day 7 Lille is above the threshold, with a still rising bilirubin, who has strong family support, no prior treatment failure, and clear insight, where the action is referral for early transplant evaluation, not continued steroids past day 7, not adding N-acetylcysteine, and not transitioning to comfort care because the data say transplant and the patient meets the criteria. Post-transplant management has its own pharmacology, with acamprosate and baclofen preferred for alcohol use disorder in significant liver disease because acamprosate isn't hepatically metabolized and baclofen has been studied directly in cirrhotics, while disulfiram and oral naltrexone are used cautiously, with addiction support continuing indefinitely, and alcohol-associated liver disease is now the leading indication for liver transplant in the U.S. So the way of thinking runs along a single continuum. Alcohol injury moves from steatosis through steatohepatitis to cirrhosis on the same biology, with reversibility at the front end and decompensation risk at the back. The acute superimposed syndrome of severe alcoholic hepatitis is identified by a MADRI above 32 or a MELD over 20, treated with prednisolone only after infection is screened, with the day 7 Lille as the response decision, and non-responders stopping steroids and being evaluated for early transplant, which is now established as a survival-saving option for highly selected patients with first decompensation, social support, and insight, because the 6-month sobriety rule is no longer the criterion, the psychosocial assessment is. The next chapter moves to the inherited liver diseases: hereditary hemochromatosis with its gene and phlebotomy to a ferritin target, Wilson disease with the Leipzig score and the chelator plus zinc treatment, and the rest of the inherited disorders, including alpha-1 antitrypsin, cystic fibrosis liver disease, polycystic liver disease, and the pediatric cholestasis spectrum. For the full chapter, the practice vignettes, and the topic-tagged question bank, head to boardpearls.com. You'll find the rest of the series on Apple Podcasts, Spotify, or wherever you listen to podcasts. That brings us to the end of episode 2 of Chapter 21, and I'll see you in the next one.